working at a place where they've had issue with just different type of central line. Some central line are long term and some are short term. And we'll be talking about that. So short term central line. Short term central lines are lines that are not tunnel. What is tunnel? Tunnel lines are lines that are surgically placed. They are threaded under the skin until it goes and enter a major vein. It is anchored in place. A short-term line, like this IG, for instance, or a subclavian that goes into the chest, they are not anchored in place. The only line, another line that is not anchored in place is the PIC line. However, it's a long-term line. You can use it for a longer period of time. A patient can keep a PIC line for like a year or sometime more, um, um, if they don't have like multiple infections. A lot of policies regarding short-term lines because we have a lot of untoward events in hospitals where patient can easily pull those lines because they're not anchored, right? They can easily pull them and they can bleed to death. Um, Safety guard for those lines is uh, if a patient has a non-tunnel line, then they need to be in an area where they are being watched. They should not be on the regular message floor. Maybe they will be in step down where they are being accessed frequently, or they should be in the ICU setting just because they have a line, a short-term CVC in. So then ideally, if in an emergency, an IJ or a subclavian was placed, then maybe we should start an early consult to the PIC line nurse to change that line so we're not incurring higher level care costs for the hospital. The patient is just sitting in ICU or in step down just because they have non-tunnel line in place. That is not good business. Again, long-term lines will be tunnel and threaded down. You can see where this line is entering the skin and then until it hit the major vein here, right? Ideally, central line, if you want to know that, or peak line, if you want to know that they are in the right place, uh, you're going probably to see the side port. The side port is the tip of the central line. The side port on X-ray, you might see it around the 7th intercostal space for proper placement, sometimes somewhere between the fifth, because somebody may have a short torso, right? Or a longer torso. So maybe somewhere between the fifth and the seventh intercostal space. That's where you have the superior vena cava, or that's where you have the lines are usually placed at the cava atrial junction. Cover atrial junction, meaning that the line doesn't necessarily enter the right atrium. They just at the mouth of the atrium, where right where the past the SVC, and then right at the mouth. That area of point of entry there is called the cava atrial junction. So if you're paying attention to your X-ray, because after we place the line, we will need to know if the line is where it needs to be before we can start infusing stuff into it. Plus, a patient have a new line placed in need to be monitored because one of the complications of line is arrhythmia. So how does the line cause that arrhythmia? If the line is too close to the SA node, to the pacemaker of the heart, is going to start to what? Tickles. Is going to start to agitate the area surrounding the pacemaker. Therefore, like an AFib, you're going to have extra beats. That's the arrhythmia. Therefore, if they can see that on X-ray, if you pay attention to the X-ray, then you say, you know what, my line has migrated down, because lines also has the ability to migrate more further or to come out of the body. The body has the ability to swallow stuff or to reject stuff. So it's also very important to see the measurement of the line, especially your peak line. It should have a number at that point of entry, or it should be documented. Let's say, just like the same thing you do for NG tube, to make sure that the placement is where it needs to be, that the measurement where they stop it is where it is still there, because it can go further. So for peak line, when you do your peak line dressing changes, you want to see that you are still at the same place, that the line didn't come out or the line didn't migrate further into the body. But in order to do that, you have to go to the original documentation and see what that measurement is supposed to be at before you go in and do your dressing change. If not, once you're doing your dressing change, you're not going to know. And it should be documented, by the way. If you have a portacat, the port will be um, about fourth intercostal space or so, usually. That's where you see the port. Okay, you have different type of ports here. You have single port and you have dual port. Sometimes the patient can have two single ports, and sometimes the patient can have a dual port. Most of the time, you're just going to see one single port. Why do we not? I personally, I prefer ports over or the other central line, because it's safer. You can de-access it when the patient go home. They don't have to worry about it for the most part. Once it's locked, it can be locked for a certain period of time before they go back and have to again flush it. So then it's not exposed. It's not showing. However, not everybody can get a port. Like a leukemia patient who have leukemia ball on their chest, they're not going to attempt to place a port. If you have some type of limitation that you are unable to get a port, like I don't know, if somebody have aggressive breast cancer and it have gone into surrounding tissues, probably that's not the person who is going to get the port. They might just get a regular PEEK line, for instance, for treatment. So when it comes to ports, the needle that we're going to use to access the port is going to be very important. Three things about ports. The needle size is going to be very important. The how you access it is going to be very important. The amount of heparin you use after you de-access the port is going to be very important. And I'll add another one. Ports are also very temperamental, meaning that sometimes it's hard to draw blood from them. And if you're unable to draw blood from any central line, you can, the patient, when you're drawing blood, the patient should have a mask, right? The patient has a mask, the head should be turned the opposite way. So you can ask the patient to move the arms around, move the arm, swing the arms around, gently swing the arms around. That helps shift that line and move it over to the side. If that doesn't work, you have flush, you've tried pulling back and it still doesn't work, you can ask the patient to cough, cough. That coughing, that pressure, it can move the line around. Most of the time, that is going to work. Again, ports are very temperamental. You may have to. Patient usually, like when I work with oncology patients, they know the drill. You can draw your blood. Okay, do you want me to move my arm? Do you want me to? They know the drill. Uh, so if you work, I'm sure there are other tricks that I'm not aware of, but these are the ones that I've used a lot in the past. Um, the needle size is going to be, we usually use the Huber needles. That's what I'm seeing in that picture, the Huber needle to access the port. What I would say is you don't want to poke the patient 5 times, just go get the right needle. It's very important to know the needle size. If this is a patient who has a port, uh, what we've done in places is we will give the patient something called a passport. In that passport, it will say if they have a central line, it will say what's the size of the central line, what's the measurement is, or what's the peak line size is, what's the measurement is, like where it's supposed to be, so we know the line didn't migrate. If they have a port, you would tell them if they have a single port or a dual port, because sometimes you can't tell by just looking at that unless you can clearly, especially if you have a dual port, you can't tell if it's one or two. But if they have two single ports, you can feel it. The passport will have everything the patient needs. Why the passport? The patient carry that around. And this would be chronic patient, right? They will carry that passport around. So let's say they end up there's an emergency and they take them to a different facility where the chart is not there. They will be able to look at that passport and they know exactly what they have. These are some of the advancements that we have made. These are something that you can discuss among your group, your shared governance group, your unit-based teams, and come up with stuff like this to protect your patients when they end up at other facilities. Needle size is going to be very important. Huber needles come in different sizes. You have half inch, you have 3/4 inch, you have 1 inch, you have 1.5 inch, and so forth. Most patients, the half inch is not going to work for them. Sometimes it doesn't even work in children. It's too short. Even though it looks like that's the size of needle, you should try. Most patients, try the 3/4 inch. If you don't know a patient, you probably want to try the 3/4 inch. If the patient is heavy set, meaning that the port, like this picture here, this patient here, I'll use a 3/4 inch because the patient is thin. This patient, they don't have a lot of tissues. You can clearly see the port. So it's not going to be hard to get into the port. I believe you can even use half an inch for this patient here, even though half an inch would not be ideal for most patients. The 3/4 inch is going to be ideal. Now, ideally, hopefully your hospital support a traumatic care, which means that you need a numbing cream, a lidocaine, EMLA, LMS that you need to apply to the site and numb the sites before you go in and poke the patient with that needle. That would be my practice. Um, Once you put the needle in, connect your flush already. You flush your extension tubing because that's going to be attached to your Huber needle. You flush it. Once you see blood drop, you are in place. Then you put your flush through, you anchor your needle, you put your bio patch, you dress it just like the way you would dress a central look. If you choose a longer needle, you have to put stuff to anchor the needle in place, like sterile gauzes, or else it's just too much. Look at the room around us. It's going to be hard to dress. That's why selecting the proper needle is very important. And educate your patients so they know their needle size. You are not probably going to know that patient. You're not going to remember that patient. You might not have a passport because not all institutions are using that. So therefore, you're going to estimate or guesstimate, right? You have to estimate the needle size or you guessed it. There's no need to guess when we're providing safe quality care. If you educate your families, your patient family to start with, you educate your patient, they will remember the needle size and they will tell you this is the needle size that they use for me, the 3/4 or the 0.75 inch, the half an inch or 0.5 inch or whatever. And I already talked about peak line. They usually place at the bedside. They can be long terms. Um, PICC lines, usually the dressing change are going to use stat lock. You can have most PICC line for your adult patient are going to start at 4 French, 4.5, 5 French. Once we get to 5 French, we have the ability to select the triple lumen PICC line or 7 French. We can usually will come on a triple lumen. Um, Always know the size of your PICC line. If you need to draw blood, if you have a central line that have different ports, I believe, let me go to the next. Like this central line here, it has a red port and a white port. It's always good to know that the red port is your bigger lumen. Therefore, if I'm giving medication and I need to draw blood, I'm probably going to draw my blood from the red lumen. That way, I don't clot the line. Plus, central lines need to be um, heparinized, um, depend on your order, um, your institutional order, whatever they choose to go with, um, to prevent them from to prevent a clot formation. If something is infusing continuously in the line, do you still need to heparinize it? The answer is yes. Again, go by your institution policy because nurses, we usually say, well, there's something continuously infusing, so my line is not going to clot. Now, that's not the clot that you're trying to prevent. You're trying to prevent a platelet aggregation along the line that is in the vein itself. Because when the line is in the vein, you occlude the path of blood flow. It causes an impedance of blood. Blood does not flow as well when it gets around the line. It does not flow as fast when it gets around the line. It tends to slow down. And when you slow things down, you're going to have platelet aggregation. That's what we're trying to prevent. Over time, that's going to cause a thrombus. Over time, that may cause your line to clot. Another line that we may use that may be large bore would be a cordis. A cordis is just a line that has a really large inducer. This bore is what we call an inducer. When you use a peripheral IV, you have the catheter, but that catheter is just a flexible rubber catheter. An inducer is a rubber catheter that is large enough that either is very large bore or is large enough that you can put something else inside. So if when they want to start a central line, they will use one of these inducers. It comes in the central line packaging. So they put it in first, it's a large bore, and then the wire. They put the wire through and then the central line through. It guides the central line. But a cordis is just an IV with a large catheter or a large inducer. And it has one side port, like in this picture. You see cordis being used more in EDs, especially in emergencies when they need a large access to give something to somebody. I've seen cordis being placed in unit now because they don't want to place a central line or they want to decrease the use of midlines. Um, Before they didn't used to have a midline. Midlines usually are fail PICC lines. PICC line that is supposed to go in and it stop halfway. We call it a midline. Please check your institution policy regarding lines that are called midline. Now, manufacturers are making line and they're specifically calling them midline because they don't go all the way to the superior vena cava at the cava atrial junction. They kind of stop halfway. So they're called midline. However, not everything can be infused through midline. Check your institution policy regarding midline and what can be infused through it. Now, another type of line that you can see is a sheath. You see this, and a sheath, it looks just like this, but it may have multiple ports instead of just that one port. And a sheath is usually placed in the cath lab. Most A lot of cath lab patients may have a sheath. A sheath can go in the vein or in the artery. When your cath lab patient come back, they might have a femoral sheath in place. They might have a radial sheath in place. If that sheath is placed in the artery and the patient pull it out, they can bleed heavily. If the sheath is in the vein, it's a large bore. They can still bleed heavily. Now, sometimes the sheath, when it's in the vein, we can infuse stop through it. Like people who come from the cath lab and they have heparin infusing, for instance. So make sure you know where the sheet is coming from so you're not connecting medication to arterial lines. How do we manage central line? Dressing changes are going to be important. They're institution policy driven. Most dressing changes are done every 7 days and PRN. With that said, I am going to say some patients have allergy to the materials that we're using for our dressing changes, and we may have to use other uh, um, material like CLC 2000, for instance, and or we may have to do gauze dressing, and in that case, that dressing change has to be changed more frequently.